I'm not actually going to talk about the Bosnia classification at all. So anyone who came here to listen about the Bosniak classification, well, we'll find out what you think at the end of my talk. The Bosnia, we always needed some way of classifying the cysts that we saw on CT scanning. And the Bosniak classification itself was first established in 1986. I'm not going to go through what the classification is. If anyone's really interested, they can go away and have a look at it themselves. And I'm sure they will do once we finish. It was modified in 2019 by Silverman. Now, the Silverman modification is still being evaluated, but it's an interesting modification, and I think we should always aim to go with the most recent work if we can. Now, the question, however, that I'm going to raise today with you is the question, in the 21st century, is the Bosniak classification the best way to actually classify renal cysts at all? And that's what I'm going to talk about this afternoon. Most of these, I will actually give you at the end the overarching paper from which my figures have been obtained. So these figures have all come from an overarching review paper, and I'll give that to you at the end. The reported accuracy of the Bosniak classification is between 89 and 95% in sensitivity, and in specificity, 59 to 76%. Now, there's no one, I'm sure, listening to me babbling away, that would in any way disagree that when you actually have a fluid-containing structure, like a pleural effusion, like a cyst, like anything else that contains fluid, there's no way that CT is as sensitive to the internal contents as MRI or ultrasound is. And I don't think there's any debate about that. We're much more sensitive to septa and other parts of the fluid-containing structure. And of course, cysts are fluid-containing structures. So the question is, why are we so reliant on the Bosniak classification when actually it's mainly looking at fluid-containing structures? This is a big question that I'm putting to you today. We have to look at the inter-observer agreements. It has been reported, well, Bosniak classification itself is reported to have inter-observer variability. Whole books have been written. In fact, recently I was asked to review a whole book on how to use the Bosniak classification. When whole books are written about an issue, then you begin to wonder, is it really wonderful? And one of the problems has always been between the Bosniak 2 and Bosniak 3. So to get around that problem, a Bosniak 2F was introduced, F being follow-up. That's because, of course, we all agree that Bosniak 3 is potentially malignant and Bosniak 2 or less are not. What happens in that narrow part between the two of them, well, you can't decide, or, you know, maybe because there are too many septa or not enough septa, etc. So the 2F was introduced, and you got around this problem by the 2F, which really says, well, we're not really sure, we're going to follow this patient up ad nauseam. Oops. Of course, recently, we have multiple other methods of examination. not just contrast, that's contrast enhanced CT scan. Now I'm going to use CECT. We have contrast enhanced ultrasound, and we have contrast enhanced MRI. Now, the work that has been done has shown that in general, they are all very similar into observer agreement. All three of them can be used to assess renal cysts. And in particular, the potential malignancy rate. However, we run into the safety issue. I'm staying away from cost. I'll just mention that CEUS is going to be cheaper than CECT and perhaps even CEMRI. I'm going to stay away from cost because when it comes to patients, at the moment, we've got to think about cost within our practice. And of course, it's very, very important, and I'm going to come to that. But in general, cost is not an issue that really affects us very much. I mean, I say that tongue in cheek, of course. However, safety is a different issue altogether. These are some reported severe reaction rates between the different modalities. They're all relatively small. The examinations are relatively safe. I'm not going to go into the arguments about whether contrast is really nephrotoxic. I mean, if you include contrast nephrotoxicity, then this is only just these figures that you're looking at is only just talking about the severe reaction rates. I'm not even going to go into figures about whether one contrast is less nephrotoxic in CT, or of course we don't use gadolinium when the EGFR is very low anyway. However, the one thing we do know is contrast and ultrasound is the ultrasound contrast is actually relatively low risk and is not nephrotoxic. Now I say that, but there are some people who actually claim that it is nephrotoxic because of cavitation. And if you don't know what cavitation is, I suggest you can always ask me at the end, but you can always go and look it up. But even then, there is a debate about it, but it's supposedly much less dangerous, if you like, to use that word, I'm using it deliberately, than the other contrast agents specified there. The one thing I haven't mentioned, of course, is that CT has a high radiation dose. And that I haven't even mentioned, but I'm going to. Work that's been done has shown that contrast enhanced ultrasound and MRI are much more sensitive to septa. I said that right at the beginning, and you all know this. If you do a CT, you don't see all the pleural, in a pleural effusion, you don't see all the septa between the effusion, within the effusion. Now, we all know that. And so this is not really exactly a very, surprising. But the danger is, of course, that because we see more septa, because we're more sensitive to the internal septation.
Can I have the other letter?
Yeah.
So I can photograph the front for him. And I just had a chat with him.
Good.
He says, where's the other envelope?
They're both in there.
Somebody's got to mute themselves. Okay, thank you.
Sorry about that, Roger.
That's all right, don't worry. Because, as we've said, we are more sensitive, we tend to upgrade the Bosniak score because we see more septa. Now that could be at the detriment of the patient. So there is a tendency to upgrade lesions rather than the other way around. We should take care because the Bosniak classification is a CT classification. And we should not be using the Bosniak classification synonymously with MR or ultrasound classification. But it's inevitable that you are going to have some cross-referencing. There's got to be a method to draw some equivalence between them. Otherwise, people having different things not going to have any equivalence. Or everybody has to have everything for comparative purposes, which is also not desirable. Now, more recently, contrast-enhanced ultrasound has been shown to be able to assess the likelihood of malignancy. Now, I specify contrast because even though I said at the start that all three modalities were useful, it was important, ultrasound wasn't used very much to do a Bosniak classification. But recently, it has been shown that there is equivalence between the two. Whenever we do any sort of, as radiologists, we always have to face limitations. All modalities have limitations. And whatever you decide to do, you have to take into account the limitations. Calcification, for example, often blocks ultrasound visualization. Calcification may cause hardening artifact on CT that has to be accounted for. And some of these cysts do have calcification to varying degree. And the tendency now, modern tendency now, I don't know if any medical students are listening. The modern tendency is to use CT, ultrasound, and imaging to solve the problem without examining the patient, without thinking about why you're doing it, sometimes I feel as a radiologist doing ultrasound that I'm sorting everybody out, and I shouldn't be sorting everybody out. It is essential to take into consideration all the non-imaging criteria. We should be an adjunct, we should be a help, not the final common path. The good thing is, of course, we are often the final common path, which is why we can go rah, rah, rah. And needless to say that all the assessments, it doesn't matter whether you're doing CT, MRI, or ultrasound, have to be made by trained individuals who understand what they are doing, particularly in these assessments between maybe Bosniak 2 and Bosniak 2F and 3. It's strange that I have to say this, but I am saying it because it is necessary to say it. And the reason I said that is because nowadays a lot of people think, oh, I'll just do an ultrasound. Oh, I'll just have a look at the CT myself, who are not trained radiologists. Now, in practice, CECT is a reference standard, but for reasons we've given, it can be inaccurate. CEUS is as good as CT and has some advantages, which I'm going to come to. And CEMRI is probably the most sensitive of all. I'm going to show you some images now where CECT has said something and ultrasound has changed it. This is this is case A. I'm only going to show you ultrasound because I'm a sonographer, but this is deliberate. This is deliberate. This patient was given a diagnosis of 2F and was sent to us for reasons that will become clear for follow-up. And it's clear that actually it's not a 2F because there's only a single symptom. So we then went on to contrast enhanced ultrasound. And you can see there's actually no uptake in that, even though we saw a septum, there's no uptake at all in that septum at all. This is not a 2F, this is not even a 2, but was designated a 2F. Next case. This patient was designated a 3. The patient came to us for an ultrasound for another reason. We did contrast. And you can see there's virtually no uptake in there at all. There are just a few septa. They're not even hardly taking anything up. This at the most is 2F. Now this is another case that was designated as a 2F, but there's absolutely no uptake in it at all. This is not a 2F. This is yet another case that was designated 2F. There are just a few strands in it, but no uptake, so it's not a 2F. Now, these next two are hyperdense cysts seen on CT, where they sent us to ultrasound because it's well known that it can be hyperdense and yet simple. And here you go, that's simple. Here's another case. And of course, that's simple as well. So this is where we have changed the diagnosis again. But although this is not changing it, they knew what they were doing here. And here is a particularly vascular area where CT wasn't really sure what was going on. And in this particular case, there is a cystic element, but there's also this abnormal area. So this patient basically went back to CT because although CT didn't know what was happening, it was obviously that there was something serious going on here. This patient went on and had a nephrectomy. Now, whereas this patient was designated a 2F on CT, but when they came to us, actually it looks more solid. And ultrasound shows there's a solid element here, contrast. So that went back to CT and was redesignated a 4 and subsequently had a nephrectomy. In conclusion, I've got about another 5 or so minutes. All modalities are complementary and not mutually exclusive. And that we think that CEUS should be the first line investigation. I'm going to come to that. CECT obviously for malignant lesions. CEMRI as a problem-solving tool. And all modalities can be used for follow-up. And here's the central word here, CEUS is preferred. And you're going to ask me why. Well, I'm going to tell you that within Peterborough now, we have taken a dictatorial decision. The point about ultrasound is it doesn't use radiation. It is the duty of clinicians not to harm the patient. Not to harm the patient. Failing to recognize malignancy is harming the patient. But diagnosing a simple cyst with triple phase CT is harming the patient. Repeated CT scans when CEUS is perfectly okay for follow-up is harming the patient. This story is not an academic exercise. Increasingly, we are doing more and more and more cross-section imaging. We're finding more and more lesions in the liver, lesions in incidental melanomas in the liver, renal cysts, ovarian cysts, etc., that we then have to investigate the investigation. We call them vomits, victims of medical technology. So it's not an academic exercise to send the patient for another CT for a triple phase when an ultrasound will do. It's not acceptable. Now, we have made a decision here that a CT simply to characterize a renal lesion will not be done unless an ultrasound is first performed. And we will not follow up our patients with repeated CT scans if we can equally do it with CEUS. Now, you can't make a dictatorial decision of that kind unless you're Boris Johnson or President Putin without some proof. So we did I'm going to read this directly. We did an audit of the 100 patients. These 100 patients are selected by PACS officers completely randomly. You're just looking at the words kidney contrast, ultrasound contrast, CT contrast. And this is what came up with on our retrospective review. Now, out of the 100 cases, 32 cases were ruled inapplicable, and that's because there was no linkage with what we wanted. Like, for example, then the two words kidney and contrast, etc., were used in the report, but had nothing to do with the actual aim of the audit. Now 9 cases did not have a CT scan, therefore comparison was not possible. So these were ultrasound who had no CT, so comparison is not possible. 5 cases had MRI for other reasons, and the ultrasound and the MRI results were the same. And 5 cases had CT, and ultrasound, and they were just cases where CT had seen hyperdense cysts, and they just wanted us to look to see whether they were simple or complex. The rest of them were on all the rest, CT and ultrasound agreed with each other on all the rest, except 11 cases. Now, in those 11 cases, 2 were downgraded by ultrasound. I showed you a couple. And 5 were upgraded by ultrasound. And that fits in with what I told you in the earlier, which is that because ultrasound and MRI are much more sensitive to septa, you tend to upgrade rather than downgrade. So we just fitted in with the rest of the CEUS community. Neither could decide went to MRI. And there were 3 cases that were actually source of dispute between us and the urologists. And I'm going to read you what the dispute was, because it's quite interesting. Case number 1. This patient had a CT which said it had a simple cyst. Ultrasound said, no, it wasn't simple, it was a 2F. MDT suggested another CT to sort out the first CT. For goodness sake, which is wrong. That wouldn't happen now. There's no way that a triple phase CT will undo ultrasound in looking inside a fluid containing area. Anyway, so what? Whether it was or not. But anyway, we resolved the issue that this patient we couldn't resolve this issue, so this patient is going to continue with CT. Next case. Next case. This is another case where CT suggested another CT to reevaluate a renal cyst. Ridiculous. Finally, we agreed we'd do an ultrasound. It turned out to be a simple cyst. So the initial decision for CT to suggest another CT, I think, was wrong. But you could argue that with me later on if you wish, because we're going to have some question answers, I hope. Is that all right, Professor Gilbert? They can get at me?
Absolutely, Roger.
And the last case, CT showed a hyperdense cyst. A repeat CT was asked to repeatedly look at the hyperdense cyst. And the person reporting the repeat CT said, why the hell am I doing this in the report? He didn't use the word hell. In the report, he said, why am I doing this? You should have sent it for ultrasound. So even the radiologist looking at it on the second CT questioned why the first CT requested the second CT. Anyway, we did an ultrasound and it was a simple cyst. It just happened to be a simple cyst. So, ladies and gentlemen, I hope that you will agree after I've spoken to you with these conclusions. You don't have to if you don't want to, but I hope you agree. And it's important because those of you who are now about to qualify as FRCR, you're going to be sitting reporting these things, and it'll be you who can say, I don't know what this is on CT, do an ultrasound, or do another triple phase CT. Or you can be sitting in an MDT room and they'll say, what is this? You should say, I think, do an ultrasound first. That's what I think. So I've said my say. I've explained why it's 21st century. I'd like to give some acknowledgements here. And while you grill me and put me on the spot, I will just show you this reference, which is an overarching review of the whole subject, from which I took my figures.